We have Dr. Vilella again, Dr. Courtney, Dr. Drew Brady, and Dr. Haydel joining us for this panel. So with that, I'm gonna run your slides, but I'm gonna hand it over to you.
Good afternoon. So as many of you heard this morning, I've sort of made a career transition over the past few years, and certainly the way I look at things and the way I do things has changed. Saqib asked me to put this talk together. Basically, the question is that component loose, right? So there's a question, and then I'm gonna show 3 cases of mine that hopefully will generate some discussion and some education. Go ahead, Saqib. So I have no relevant financial disclosure. As an introduction, hip and knee replacements are 2 of the most successful surgical procedures. As the population get older, people are still more active, and with ever improving technology, hip and knee replacements are becoming younger and are becoming more and more common in younger patients. The downside of all this is that even more common surgical procedures have a continued increase in the prevalence of complications. Periprosthetic fractures are the 3rd most common reason for reoperation, with a reported incidence of about 18%, increasing at a rate of about 216%. The treatment of periprosthetic fractures is complex, is one of the major challenges facing reconstructive orthopedic surgeons. And as these fractures continue to be encountered with greater frequency, you have to have accurate diagnosis and treatment. That in turn will be required by a greater amount or a greater breadth of orthopedic surgeons with different specialties. And obviously, your implants that you'll need to treat these fractures will need to be readily available. The classification directs their treatment. We're all familiar with the Vancouver Classification, published by Duncan and Mastery in 1995. Basically, it's the 3 most important factors. Number 1 is where is the fracture located? What is the stability of the stem? And number 3, what is the quality of the remaining bone stock? And the classification has been proven validated and reliable. Type A is around the greater or the lesser, also known as a G or a L. Usually the way I think about this, I think about the extremes. A type C is well below the stem. And then a type B is at or around the stem, and that's subdivided into a B1, B2, and B3. The B1 is at the stem with just a little bit at the tip, and the stem is well fixed. B2, same location, the stem has loosening. And B3, same location, the fracture shows loosening, and there's a decrease in bone stock. Really, the treatment, most treatments should be treated with surgical stabilization. Non-operative management has gone the way of history. And the 2 basic tenets of treatment is, number 1, if the implant is stable, treat the fracture. Number 2, if the implant is loose, revise the implant and fix the fracture if necessary. So I know the images are a little bit hazy, but with that, I'd like to introduce the cases. This young lady is one of my first periprosthetic cases. She's 67. She's a piano teacher at Juilliard in New York. And her husband actually was a first violinist with the Cleveland Symphony Orchestra when they came to play their winter session here in Miami. She was leaving she had a displaced femoral neck fracture treated in New York, I think either joint diseases or HSS, treated with this bipolar hemiarthroplasty 2 years before her injury. She was leaving the hotel and basically she got run over by a bus. She has no previous history of infection. Per history, she has no previous history of thigh pain. With that, I'd like to include the members of the panel. Dr. Courtney, do you have any comments, any questions?
Sure. Thanks, Fernando, and thanks, Saqib and Asif for putting this together. Despite the COVID crisis, I think it's great we can still bring the residents together across the city and do some teaching. So this one, as you talked about the Vancouver classification, I think it's also important to know timing and know where the fixation is of each of the implants. So this lady sounds like she had a well-functioning hip stem for 2 years. And then this implant, again, is going to be getting its fixation more proximally. So the implant looks well fixed. I think this is a Vancouver B1, and I would attempt to fix this with a proximal femoral locking plate.
So one of the questions I always argue with my boss, because my boss has been a pure traumatologist for 40 years, and he believes there's really no such thing as a B1. They're all B2s. But this is the case in point to this particular patient, patient with with previous total hips or bipolar hemiarthroplasties also get hit by buses. Dr. Brady, we've pretty much narrowed it down to a B1. How would you approach this? How would you position the patient? What would be your strategy to take care of this?
So I think I agree it's a B1. If this was not 2 years out, then I think I'd be considering something different and maybe getting the CAT scan first just to make sure that it really was stable. But this looks like a stable stem. I'd approach this plan on with a long plate. I would probably position the patient supine with a little bit of a bump underneath of the ipsilateral hip so that I can have full access to the lateral aspect of the femur from proximal to distal.
Well, I along those lines, this was early on in my career. At that time, I still considered myself a trauma surgeon. I actually positioned her on a fracture table. I'm a big fan of fracture tables in residency. It allows you to maintain the reduction. The fracture table sort of is not a resident, right? It doesn't sweat, it doesn't shake, and you can maintain the reduction. So I actually propped her up on a fracture table, which is something that I wouldn't do. Chris, we've talked about plates. Do you have any particular type of plate that you would like to use, or any particular brand that you would like to use?
No, I mean, I thought we weren't supposed to talk about particular brands. Are you
Nope.
just referring to like a hook plate or like a?
Okay, I mean a hook plate, a distal femoral plate. Which one would you use?
I mean, I think, just kind of looking at this, it looks like that fracture goes pretty high. And, if you use kind of a standard plate that's going to maybe stop on the trochanteric ridge, you may have a pretty short lever arm up top. So probably using a long hook plate to get all the way around the greater trochanter so you can have cables and also screws above that lesser trochanter would be ideal. And then take that plate distally at least 2 bone diameters distal to that stem or the fracture site.
Do you have any on the proximal fixation? Do you have any combination of cerclage or periprosthetic or locking screws or non-locking screws that you would like, that is your particular protocol?
I would probably use 1 or 2 cables, but I would try to get screws around that stem if possible. Sometimes it's difficult. So you could use unicortical locking screws as well in conjunction with the cables.
Okay, Socket, can we go to the next slide, please? So this is an intra-op fluoro. I used a 4-5 plate. I used the big spine benders to get the plate to contour around the bone. Can we go to the next slide, please? We actually were able to achieve anatomic reduction with an AP screw. We bent the plate, we compressed the plate. We compressed the plate down to the bone, and we were able to also send in a lag screw through the plate itself into the fracture in a different plane. Can you go through the next slide, please? So this is the final construct. I usually prefer a combination of 3 wires and 3 short periprosthetic screws. If I can get screws around the implant, get good bicortical bite, I will pursue that. That being said, I think that Chris is right. I do have at least 2 lengths distance past the fracture with the length of the plate, but I've gone a little bit more aggressive now, and I actually do my patients lateral decube, not on a fracture table for reasons that we'll talk about in a minute. And can we show the next slide, please? So this is the type of fixation I go for now. I actually try to span the femur a little bit more aggressively to prevent any other fractures later on, peri-implant fractures, or creating a stress riser at or about the knee. Gentlemen, do you have any other questions, comments as to this case?
I think that's a good point, and Derek Donegan pointed that out in the chat room. Trying to protect, most of these patients are elderly, osteoporotic, and you want to do what you can to protect the entire femur. As far as positioning, I'm sure you'll get in with this with the next case. This one at least was relatively straightforward. You're pretty confident that the implant was well fixed. but B1 fractures are actually really, really rare. And if you're on the fence between that B1, B2, it's tough to revise their hip on a fracture table. And for most of these, other than say maybe that one, which was very straightforward as a B1, I'm also positioning them lateral decubitus because I can do my revision through a posterior approach there.
That's excellent foreshadowing, Dr. Courtney. Thank you very much. Dr. Brady, Dr. Haydel, you have any comments?
I agree. I think that you've touched on the biggest thing that I was going to say. These are always more distal than I think they're going to be. So I tend to plate the whole femur with a distal femoral type plate really long.
Right. So, I mean, as my career has evolved, you know, you live and you learn. And now for the few B1s that I actually treat, I actually use a distal femoral plate that is contoured to the bone distally, and then I contour it up in the greater. And obviously, I mean, your fixation into the articular block of the knee doesn't have to be that aggressive, but basically spanning the femur to protect the femur. Okay. Can we go to the next case, please? Again, a little bit of a hazy image. I apologize for that. This is a 77-year-old Haitian American lady who on Sunday morning was coming down the steps of her church with her husband, and she tripped and fell and had a sudden onset of left thigh pain. She's hypertensive, she's diabetic. She did not have any history of any thigh pain or hip pain before this happened. She had this total hip done at a local community hospital approximately, I think it was maybe 10 years before admission. She arrived at our hospital. We tried to transfer her out to her primary surgeon. Her primary surgeon sort of did not want to take her because he said, quote unquote, he was too busy. And she was taken care of at my trauma center. Max, do you have any comments as to this x-ray? What do you think?
Sure. So this fracture goes through the cement mantle. So the implant's definitely loose. You can see the sim subsided. Oftentimes, if you have serial radiographs, it can be helpful to look at the positioning of the stems. But most of the time, these patients are transferred in from outside facilities, so you don't get to see that. We're seeing more and more, actually younger guys like myself are cementing more and more stems. So we're going to be seeing more and more of these patients as well. So this needs a revision. So what I typically do in these circumstances is it's going to be tough to get fixation right down the canal. I'm going to put a prophylactic cable distally. I'll turn this 2-part fracture into a 3-part fracture. So basically make it an extended trochanteric osteotomy, just cutting down the lateral cortex with a small microsagittal or the thin patella saw blade. You're able to get access to remove all the cement, because that's going to be one of the hardest things with this particular part of the case. And then I prefer monoblock fluted tapered titanium stems. If you want to do a modular one, that's fine too.
So this, if you look at the x-ray very clearly, obviously there's evidence of subsidence. There's radiolucent lines throughout the proximal femur. You can see the collar actually has sort of subsided into her lesser. And if you really critically look at the medial cement mantle, you can see a crack in the cement. So this is obviously an example of a B2. Dr. Brady, you mentioned a minute ago you might want to get a CT. Is there any further workup that you would get on this patient? And second question is, how quickly would you try to get this patient to the OR?
So I don't think there's any need for any further radiographic workup as far as I can tell. It would be nice to see what it looked like before, because I'm not sure if this was subsided because of the fracture or because this was already loose. It looks to me like it was already loose and then maybe subsided and then subsequently fractured. So I'd be worried about either infection, number one, and also whether the acetabular component was loose as well. So this is not an emergency to get to the operating room. I think you've got a couple of days to sort of figure those things out. I don't necessarily think I would aspirate it to see if there was an infection, but I'd be prepared in the operating room to treat it like it was an infection if that happened. If it wasn't an infection and I could go ahead and do the definitive treatment at the first stage, I'd be prepared to switch out that acetabular component just in case.
As you bring up a very good point, right? I mean, yeah, you always think about the fracture and you're looking at the fracture, but you have to be ready, willing, and able to revise the acetabulum, either redo the whole thing or maybe change the liner if you have access to that particular liner, which is sometimes a problem. Or you can also just take another liner and, you know, burr it up a little bit and cement it into the old cup. Chris, would you also do an extended trochanteric osteotomy on this, or would you just try to take it out?
I'm gonna be honest with you. This is one of those that I would probably give to one of my joints guys.
Okay. Would you be willing to fix this and revise her later? Would you advocate for that?
Like fix a fracture and then revise the component later? No.
Yep.
I think it should be dealt with in one shot.
Good.
I mean,
So
as long as it's not infected, that's a whole other thing.
Right. So this particular case was one of my early experiences in complex arthroplasty. At the time, sort of my venturing into ETO was not exactly to my confidence level. And what I did is I actually opened up the fracture, and I was able to clear the shoulder around the greater trochanter to make a tunnel to remove the implant. I actually brought out the implant through the proximal femur. Saket, can we go to the next slide, please? So there's the implant. You can tell that the cement mantle is cracked. Next slide, please. So this is what I did. I put in a long stem implant. If you look very carefully, there's some smaller cerclage wire over the fracture itself, keeping it reduced. And I put in a stem that bypasses the fracture by wait, not yet. Go back. Okay. I bypasses the fracture by about 2 cortical lengths. And then I added femoral allograft from the University of Miami tissue bank to the lateral cortex of the femur. Dr. Courtney, I do have one question for you. You mentioned that you would handle this with an extended trochanteric osteotomy. Once, a lot of these fractures, they're not simple spiral ones like this. They actually have multiple fracture lines up the femur. Is your strategy to get the stem fixed distally and then wrap the bone around the implant, or would you rather reduce everything, sort of cerclage it, and then perform your implant?
I think it depends on the fracture. Converting the periprosthetic to an ETO for this would just be more to get the cement out. If it's one of those, the calcar gets fractured that we all see with a flat wedge tapered stem in a patient that's 2 to 4 weeks out from surgery, that you can put a clamp around it, put a cable around it, and then pot your stem. That's easy to do. But otherwise, again, since most of these revision stems are getting diaphyseal fixation, I'll pot the stem first and then cable the fracture around it.
Right. I usually try to reduce the fracture, try to put some cables around it, then ream the stem and put down the stem. I think it provides a little bit more elegant reduction. I think sometimes the ability to wrap the femur around the stem that's already in might be hindered by some cancellous bone or some cortical bone that hasn't been reamed out, so you might get a less than anatomic reduction. Important point, when you ream these, please have your tech try to preserve the cancellous bone that you are reaming out so you can use it as bone graft later. Can we go to the next slide, please? So this is her about 3 years after her initial surgery. She has no pain. She's doing very well. She's going to church back on Sundays. And you can see very good restoration of the bone stock of her lateral femur and incorporation of the femoral allograft.
Fernando, do you use femoral allograft on a lot of these? What's your indication for allograft?
I think this was my first one. And for her, if you look at the pre-op injury films, her lateral femoral cortex was not that thick. Again, we have the privilege of having the University of Miami tissue bank a stone's throw away, so we just sort of call up and within 30 minutes we can have a femoral allograft. I was really aggressive. I wanted to do the right thing. As I've gotten older and wiser and more experienced, I sort of see thicker femurs, then I tend to stay away from the allograft itself. Okay. Any comments or questions, gentlemen?
Yeah, I agree with you. I rarely use allograft. I admit it's freaking out about an infection as a joints guy, but I think the data is pretty clear that in most cases you don't need it.
Chris, Dr. Brady, you have any comments?
You never say never and never say always, but I've not used a femoral allograft in practice. Last time I saw it done was the residency.
Okay. Let's go on to the next case, please. So really, determination of implant determination of implant stability is imperative. The underdiagnosis is actually considered the main reason for failure of fixation in Vancouver B1 fractures. And some authors have suggested that the prosthesis should be considered loose until otherwise. In my own personal opinion, and what I've done now as my career has evolved, if I have a doubt that it's a B1 or a B2, I will place the patient lateral DQ position, big lateral approach, proximally posterolaterally, and then basically physically look at the implant and say, okay, this is loose, we're going to revise it. This is well fixed, we're going to fix it. It takes a little bit of an extra discussion with the patient. You tell them that you have to be prepared for both. But that's really my way of sort of addressing this controversy. Next slide, please. So I sort of think that we've talked about two very classic scenarios. I'd like to present this one as a not so classic scenario. This is an 88-year-old. He was born in Eastern Europe, but grew up in London during the Battle of Britain, during the German siege. And he actually grew up and became himself a very good electrical engineer, and he became a very big industrialist in Europe. So he was on his private island in Antigua. He had this hip, I think, done at Mayo maybe 15, 18 years before. He was at his private island in Antigua. He fell, had a sudden onset of hip pain, and called the private ambulance and got himself to the emergency room at Jackson Memorial Hospital. Dr. Courtney, any comments?
Sure. So this one you can start to see probably has some osteolysis. It's not a weight-bearing film, so you can't just look at the thickness of the poly, but you can see some osteolysis in zones 1 and 7 of his femur. And I would bet in my hands as an arthroplasty surgeon, I'm going to go in and revise this. I don't want to rely too much on trying to get an anatomic reduction. I'm going to revise his stem again. I'm going to convert this to a 3-part fracture with an osteotomy, get the stem out, and I'll let him weight bear as tolerated if I'm happy with my fixation distally with my titanium fluted stem.
Are you concerned about that medial spike in the shaft?
Yeah, I am, and that's why I think trying to get I think his bone quality proximally is going to be very poor. He's going to have some wear and some osteolysis. I think I think the stem is probably well fixed. If the people here that want to consider plating it, and I think that's a completely reasonable option to do. But in my hands, I'm gonna revise this. I'm gonna put a longer stem, and I'm gonna let him weight bear as tolerated. Dr.
Brady, any comments?
I think Dr. Courtney just touched on what I thought. He looks like he's got some osteolysis, and that this is on its way to becoming a loose stem, but I wouldn't doubt if once you got in there, you struggled to get the stem out, and you thought it was just going to slip right out, and it didn't. But I think in general, I would treat this as if the stem was loose, and I'd be prepared to revise the whole femur and not just do an internal fixation. But I'd also be ready to have some extra techniques, maybe creating an extra osteotomy site so that I could actually get the stem out, because I think he'll fight with it otherwise.
Chris, if you were to fix it, how would you fix it?
If I'm not going to do anything with the prosthesis, I think a long locking plate would probably be best and protect the entire femur.
Can we go to the next slide, please? This is a X-ray of the knee. Next slide, please. So this is further along in my arthroplasty career. We got in there, the stem was actually well fixed, but that spike of the distal shaft of the femur actually went very high up into the trochanteric region. And I felt that fixing it would be a little bit of a problem in terms of the ability to get good proximal fixation. So I did what Dr. Courtney has been mentioning, which is I took the fracture and essentially converted it into an extended trochanteric osteotomy, and basically just put in a long stem prosthesis, wrap some allograft, and wrap the greater trochanter with wire and the claw. Can we go to the next slide, please? This is a very important point. I do these under fluoro. I want to see the reamer distally to make sure that I don't perforate anteriorly over the distal femur. Next slide, please. this is, I think this is that he was able to stay at our hospital in the rehab facility for about 6 weeks. And by this time, you can already see some bones starting to form. Again, the benefits of revising him early with good diaphyseal fixation with his implant was the ability to have him weight bear as tolerated with certain amount of certainty, you know, sort of being concerned for his grade or make sure it doesn't evolve soft. But again, you know, I sort of thought to myself that, well, maybe I'm revising this B1, but I'm going to take advantage of this and get him up and walking as quickly as I can. Next slide, please. Does anybody have any comments as to that case? Chris, Dr. Brady, or Dr. Courtney?
No, I'm good.
Yeah, it looks great. I would comment your comment about the perforation, I think, is really important. So this fracture was very long and extended distally. So you needed a longer stem. I typically go as short of a stem as you can. Most of these patients, and we hear about it classically with nails, radius of curvature mismatch in elderly patients. And it's the same thing in revision hip stems. And I've had one or two I've perforated distally. I recognized one of them intraoperatively, another one I had to take back because I saw it on the PACU film.
Sakib, I think that's it for us. Thank you very much, gentlemen.
Yeah, that's it. Thank you guys very much. Much appreciated.
Thank you.
Thank you.